morning, everybody. This is a very unusual edition of Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association. I am Lisa Salberg, and I am live in DC, where I attended the Rally for Medical Research. If you're watching the video, you see the t-shirt. I'm in L'Enfant Plaza, so I'm in the Watergate buildings. And my hotel room looks out to the offices where Watergate all happened. So I'm in the middle of it, ladies and gentlemen. And my guest today is Dr. Matthew Martinez, who's coming to us live from Brazil. Matt, what's up?
How are you? Thanks for having me. We're excited. I don't speak a lick of Portuguese, so it's been a challenge.
I had the same experience when I went there, but they're all very kind and were very respectful that I didn't understand. So I hope you're having the same experience. So I have a whole bunch of updates, but as we changed up Tales from the Heart, the first few minutes are what's new and what's hot. So Matt, what's new and what's hot in HCM in your point of view today?
Well, I mean, you can't forget about what just happened at ESC. So 2 big trials. I think the first one is the positive trial. So let's talk about that. That was Maple. That's aficamten, sort of the cousin, similar mechanism as mavacamten, against head-to-head a beta blocker. And what it showed was what most of us thought it would show was that aficamten alone was better than beta blocker alone. And I think it also showed that at higher doses, 150 to 200, there was a significant negative effect of beta blockers. So when you think about the last 50 years of HCM care, this is an incredibly important landmark study.
Could not agree more. It was exciting to be in the room to hear that information imparted live. There's something about like getting it right off that slide when it pops and seeing everybody's reaction to a full room. There had to be 3,000-4,000 people in the room for that one. It was a big crowded room.
And I like to hear the audience response, right? When things come up and they didn't expect it, the effect is pretty cool to listen to.
It's the best sigh ever when it's positive, and it's so heart crushing when it's negative. True. And I've seen both happen with things that we might have thought were going another way. So it was a happy day, and there were lots of smiles from lots of investigators who worked really hard to get that data out there. So thanks to each and every one.
No doubt about it.
Everyone.
Agreed.
So what else happened at ESC that you thought was cool?
I think the other big one, obviously is Odyssey, and it didn't show us what we hoped it would. It's a mavacamten for non-obstructive hypertrophic cardiomyopathy. We're still looking for a good therapy here, something that's really going to move the needle. And what it showed was that there was essentially no benefit. The p-value was close, 0.06. But not enough to meet its primary endpoints, right? So it didn't improve peak VO2, and it didn't improve symptoms. The biggest issue was that it caused LV dysfunction. So I think it causes us to pause a high number of folks with LV dysfunction, and causes us to think about where the dose is too high. Patient selection seems to really matter. And we know that because diastolic parameters improved. So there were some things that were signals towards benefit, which I think is the positive of that study. But I think there's more work to be done, and we still have a case yet to come, and of course movement from Imbria and others I think are going to help us move towards a better day for non-obstructive patients. So stay tuned. I think there's more coming from that stress.
I think so too. And one of the other really amazing things that happened at ESC, and this is super cute. A gentleman came to the HCM Academy booth and stopped in his tracks, Matt, and he just stared at me. It was kind of strange. And then he comes in and he says, "Tales from the Heart with Matt Martinez." And I looked at him and I'm like, "Oh, you listen." "Oh, yes." His name is Lucky. He's a physician in the Philippines, and he was a super great guy. And I'll post some pictures of he and I on social media to bring him into the conversation. But Matt, he loves you. He loves you. Appreciates everything you do.
Well, thank you. Thank you for anyone who thinks of that. I'll take it, and to Lucky specifically. Thanks for giving me the shout out.
Yeah, I thought it was super cool. Okay, so I mentioned it in the last podcast too, because it was just he was so endearing. He was just such a nice guy, and really appreciated being able to get information in this casual manner and really hear what people think and get to know the people behind the articles, right? So we're going to try to keep doing more of this. So it's a lot of fun. I do want to acknowledge yesterday, not only that I was here on Capitol Hill And not only what I was doing here was rallying for funding for medical research through to the NIH, both intramural and extramural funding. But yesterday was September 18th, and September 18th is actually a really special day in hypertrophic cardiomyopathy, as it is the date the letter was written by Eugene Brunwald, diagnosing Mr. Claude Brady as the first patient with what we now know to be hypertrophic cardiomyopathy. The letter refers to it as functional aortic stenosis. And that was 66 years ago yesterday at the NIH. And I thought it appropriate that when I did my Hill visits and I spoke to each person, I let them know that 66 years ago today, the disease that I represent was identified at the NIH. And in 66 years, we've been able to bring science so far. And the contributions of NIH to that research in the 50s, 60s, 70s, 80s was the best research in the entire world on the disease at that time. Unfortunately, if you know my story, in the 90s, that program broke and a bad guy got in and did some bad things and the program broke. But that doesn't take anything away from the institution and the people behind it. So I was here on the anniversary of the first diagnosis of HCM, lobbying for additional funding for research. So I thought that was kind of my cool thing that I did this week. So I kind of...
Very cool. Love the history. Love the history.
I am so geeky on the history, and I could talk about the Brunwald-Morrow friendship and partnership for hours on end, but that's not today's podcast. So, Matt, the topic of the month, we used to call it Septal Reduction September, and now I think we want to call it obstruction obliteration instead of septal reduction, because is that really what we're doing anymore? Is it septal reduction? Is it gradient management? How do you look at obstruction in 2025?
So I still think septal reduction therapy has to start with a discussion about what we've done for 50 plus years, right? So surgical intervention is still the most durable, tried and true option for management of gradient reduction. So I think that's the most important thing. It's challenging to do. Not a lot of surgeons are able to do it. Operating inside the heart is different for surgeons than it is outside the heart. Replacing an aortic valve, replacing a mitral valve is different than sort of digging in and carving through that muscle. And if that is your option, then septal reduction therapy is still surgical. It has to be part of the discussion. But as Steve Ahmed always says, to me when he was training me, medical therapy first, right? So we should be talking to folks about medicines. And nowadays, after surgical therapy, I usually go towards discussion about whether or not disopyramide, whether or not one of the myosin inhibitors, a research option or an FDA-approved option, and some level of beta blocker. I haven't used high doses of beta blocker or calcium channel blocker in a long, long time. I find patients get significantly worse when you get above 100. You get chronotropic incompetence where the heart rate is now held down. So even normal activities like walking up a flight of stairs can be very difficult with or without obstruction, because now you prevented the heart rate from normally rising to give you that opportunity. So I still think you start with all three of those options when you get through baseline therapy. Now, I think that's going to change. In the next year or two, the guidelines is almost certainly going to get updated where we start to say maybe the myosin inhibitors come earlier or at a earlier equal to lower threshold thing before we start to dial up the beta blockers like we used to. I think that's where most of it starts. Now, there are folks who will benefit from septal reduction therapy through a catheter-based approach. And this is still an evolving technique, although we've done alcohol ablations for a long, long time. What always gets lost in this discussion is that when you consider yourself an alcohol ablation, recognize that over the age of 65, there may be equal But younger people, in my opinion, there's potential for harm. Higher risk for pacemakers, especially in women. There is a higher risk, I think, of residual obstruction in those who are really thicker. So under the age of 65, typically medical, typically surgical for me. Over the age of 65, we start to think about septal reduction therapy. But then there's other parts to this discussion. What's their EKG look like? If they have existing conduction disease, the EKG is abnormal, maybe we ought to worry about the risk of pacemaker. So some patients will say, no problem. I'm okay with that. I have an existing left bundle branch block. You're going to give me a right bundle branch block in many scenarios after a alcohol ablation. I'm going to probably need a pacemaker, but I'm okay with that. But I want to have that discussion up front with you rather than the fire drill afterwards where we say you need a pacemaker right now. There's also, does the anatomy work at all? Does the septal perforator, the blood vessel, does it actually supply the area where the muscle is thick and there's septal contact? So it's not just thickness, right? It's where the valve touches up against that muscle. So if the septal perforator supplies down here and you miss the septal reduction, you're going to cause the infarction down here and the pain will continue. So you've got to make sure all that fits. It does still require some expertise. There are some folks who've been doing this a long time, some real experts, and I would encourage you that if you're considering that, to have a discussion with folks who do this often. I would say the same thing with septal reduction surgery as well. It's a challenging surgery. You really need to have some experience and some expertise in this. And then I think I heard Lisa Salberg say this once. We're coming up with novel ways to torture the septum. and there are clearly some evolving techniques. There's the sesame technique, which sort of burns open the septum and kind of fillets it open.
Fillet, exactly the words we want to learn about our heart. Go ahead.
But fillet it open in a elegant way, kind of. I think that's one option. The other option is we're putting needles actually directly into the septum, and then you kind of heat up the needle and you kind of melt the muscle away. Again, for me and my patients, that's going to be a complicated conversation for those who don't qualify for some of the other major therapies that we know work.
Exactly. We have been trying to figure out ways to assault that septum for many, many decades now. We've cut it, we've made troughs, we've gone wide, we've gone deep, we've done all kinds of things to resection it. The least invasive methods seem the most attractive to patients. However, it's not always going to be so easy to figure out which is the best way, because we're not going to have the kind of trials in these procedures that I think we're going to have in drug trials.
Yeah.
So people are going to want to look at this and say, what do we do? And well, is sesame better than this radio frequency approach versus alcohol septal ablation versus surgical myectomy? I think that's going to be really, really, really hard for all of us because the numbers are small and the patient selection is so unique. It's going to be hard to know. So I know I'm going to be getting the question, how do I know I'm a good candidate for? And the answer is right now, I don't think anybody can tell you specifically sesame versus radio frequency versus alcohol. Surgery, we got great data on, but in alcohol, we have some really solid data on, but there's some tainting in that early literature that makes it a little hard. So I don't know, dude, this one's going to be hard.
Yeah, and I'll tell you, if you're a patient and you're listening, when you talk to your doctor, your HCM person, they should be really discussing all these options with you, including some of the research options, because we know that you can be a little ahead of the curve for those who don't want to go on the FDA approved ones or the evolving ones that will likely be FDA approved. But I think you should ask your doctor if they can't give you a description of all of those. Ask for another opinion, and then ask to meet with somebody who's done these. There's lots of centers who do more and more of these. I think that's important to have that discussion with somebody with all of the options, because what I don't like is when they come to me after one's already done, and then I'm like, well, probably. So now we have an alcohol ablation that failed. You have a pacemaker. You're not any better. We're going to try a myosin inhibitor and hope that it doesn't cause LV dysfunction. Otherwise, we're going to go to the OR. So that's really challenging to sort of backtrack.
We just had a patient meeting in Baltimore last weekend, and a client of probably 20 years, got up and said, what do you think about doing an alcohol ablation to see if it works and then moving on to myectomy? And the answer was, well, there's some risks there and you might end up with a pacemaker. Unfortunately, 20 years ago when this guy had his alcohol ablation, nobody told him that. And when it didn't work and he had to go on to myectomy, he became pacer dependent. Knowing in advance what all of the consequences, positive and negative, are is critically important. So I think it's really incumbent upon us to really come forward and come together as multidisciplinary organizations to get the data in a place where we can make good decisions for patients and really do our best. And I think we're moving towards that in a lot of different ways. We're being more collaborative in data share, and I think that's going to help us get to better answers sooner.
Yeah, agreed. I think it's important. That conversation comes up a lot where people say, can I just try alcohol ablation? And I've heard some surgeons say, well, that's fine. It tells me the places that I don't need to go anymore. I need to clean up the rest of it. And others who say, boy, operating through a previously scarred myocardium is not a lot of fun. And then, as you mentioned very, very nicely, conduction disease is enhanced in that group. And that's a real problem. And again, as you say, I want to have that conversation with you up front. I'm okay if you're willing to take those risks. I'm just not okay if nobody told you those risks and they sort of fall on your lap anyway, because they're going to happen. I just want you to know about it.
Exactly. I popped a question up on the screen from Lorraine. She has myasthenia gravis and obstruction. Do those two diagnoses make things more complicated? What do we know?
Yeah, certainly more complicated. So I think it makes it more complicated for a surgical discussion, right? You would want to ask about how controlled this is. You'd want to involve the multidisciplinary team. Is this going to affect the surgical risks? And then is it going to affect medicines like disopyramide? So is it going to make the symptoms of disopyramide potentially worse? Absolutely. And then, is this a candidate? This is the group we're talking about. They've got a bad kidney. They've got bad kidney disease. They've got bad lung disease, or they've got a neurologic weakness that makes potentially prolonged time on a ventilator post-surgery an opportunity to talk to folks about alcoholization. And then, of course, I don't know if you're asking me this or not, but can we use this myosin inhibitors in this group? I don't know. I don't know that there's any data on that. I would be upfront and honest and say, let's try it. This is probably somebody I'd start on a lower dose on and creep up nice and slow and see if we can't remove that obstruction if we're going to go the medicine way.
Fantastic. Thanks for addressing the question from the audience. And you're welcome to put your questions in at any time and we'll address them as we can, but no consult by podcast. Okay, so you brought up something that as soon as I dropped the news to the community that beta blockers did not respond as well as myosin inhibitors in obstructed HCM, and there may be a paradigm shift in terms of where we start treatment, and that may be coming soon. We haven't gotten there yet. But can we please just discuss for a quick second beta blockers in general? We were speaking of beta blockers for obstruction. Can you talk a little bit about the role of beta blockers with AFib management and rate control and potentially other symptoms?
Yeah, that's a great question. So I think we always want to put things into a neat box, but there's complexities with this. So if you've got, as an example, some brief runs of non-sustained VT, either with or without an ICD, maybe not enough to meet criteria for an ICD, or you already have an ICD and we're trying to control the symptoms of non-sustained VT, well then beta blockers are still helpful, right? They suppress that PVC. Sotalol is another drug we use to suppress PVCs, non-sustained VT, rhythm change from the bottom chamber of the heart. And so sotalol has a beta blocker sort of a beta blocker component to it as well. So they're still good drugs, right? But they're not things we're going to just not use anymore. And then atrial fibrillation is the same way. It controls the heart rate in atrial fib. It doesn't mean we're throwing out beta blockers as a medical therapy, but we have learned more. So let me give the audience an example. 50 or 60 years ago, 50, 40, beta blockers were the primary therapy for high blood pressure. Most of the time, we're not using beta blockers for high blood pressure anymore. Why? Because better drugs came along, right? They were replaced by better drugs who are more effective with less side effects than we do now. And I think we're going to see the same thing with beta blockers. We've talked about this in other aspects of HCM. Nobody was doing it wrong. This is what the available evidence and the opportunities we had. Remember that if we didn't have a beta blocker 10, 15 years ago, the option was surgery. Or alcohol ablation. So I think beta blockers still have a role in atrial fibrillation. They control the heart rate. They can also help people with anxiety. They can take away some stress-related phenomenon. It's not really a great antiarrhythmic drug. It doesn't keep you out of atrial fib, although it does control the heart rate and often will keep you from going into atrial fib more often. So it's a really important question and some nuances to this for sure.
That makes a lot of sense. And once I put a live video out from ESC and I'm like, here's the data. Immediately people are like, can I throw away my beta blockers? I'm like, stop. Do not throw away your beta blockers. Do not stop taking your medication. Please wait and talk to your team about what new options may be available for you. So I think
Agreed. So this is critical because if you're on 25 or 50 of beta blocker, many people tolerate that very, very well. In fact, I've had mavacamten patients who I've taken off of beta blocker and they say, I felt a little better with the beta blocker. Could I have a little bit of beta blocker, 12 and a half, 25? It sort of controls the heart rate a little bit, takes away, I think, some of the anxiety and probably some of those extra beats. So it's not throw it away. It is talk to your doctor about whether or not we're using this effectively or not. If you're on a myosin inhibitor plus 150 of beta blocker, we probably ought to reduce the beta blocker, right? I mean, it's way too much beta blocker.
Okay, you said something that's a trigger word for me, and we don't know the answers to what I'm about to dive into, and I hope that we can look at this as an area of research.
Yeah.
Okay, you said we put a little beta blocker on to deal with the anxiety. I hear you, and I think that's what it looks like on the surface, but I have a hypothesis that I would like to try to prove or disprove. Okay. I believe that the HCM heart is very sensitive to adrenaline. I think we are just extra sensitive. It's not a psychological anxiety. This is a physical manifestation of anxiety that lives right here in our chest. I call it the cat chasing its tail. Because you feel a little stressed and then you drop a little more adrenaline and then your heart starts racing a little bit more, which makes you more anxious. And then it goes to your head. But I think our trigger point starts in the heart, not in the head. And that little bit of beta blocker does block that fight or flight response and does make it a little bit easier for our heart to address the adrenaline in dysregulation. Yeah. Does that make sense to you, the doctor?
For sure. I think it's part of the component as well. So let's take another half step back and say, I think everybody has anxiety. I think that stressors in your life make you nervous. I don't have HCM in any way, but if I get stressed in my life, I feel it. I feel that pressure. I feel like someone's standing on me and something's not right. And then I kind of let it go. For me, a lot of time it's exercise that gets me through that. So you're absolutely right. This is a fight or flight mechanism. This is a rise in heart rate. There's definitely an adrenaline burst to that. We know that people use this for stage talks, right? If you're going to give a talk, if you're going to give a talk in front of your board, so people use this for Toastmasters, right? It really kind of takes that heart rate down and makes you feel better. So I agree with you. This is not like a head problem, right? You don't have a mental problem. This is that you are feeling it in your heart. And there's no question that HCM patients, man, you folks feel everything. A little PVC, people can tell you immediately when you go into atrial fib. It was yesterday at 12:12, doctor. I'm like, how do you know that? We look at the watch and of course they're right. They can feel it. And you're right. They definitely feel it more in their heart. And I think the beta blocker helps with that.
Thank you. But we need to try to measure that a little bit more. And it's not being done because I don't think beta blockers need to go away. And I don't think that they are as bad as some people make them out to be when they're given at low doses for the right reason. But when somebody says, I don't feel well, and they go from 50 to 75 to 100 to 150 to 200, it's enough to knock out a small horse, right? And you're asking a normal life. It doesn't really work so well. So everything in its place and its time. And oh, by the way, as most beta blockers are generic today, as I am in DC, I will be posting a Senate hearing that occurred 2 days ago on the generic drug quality issue. things are moving here in Washington in a positive direction in terms of FDA, the House, the Senate, everybody understanding that generic drug quality is a national issue and that we need to address it as a matter of homeland security, actually. So it's moving, it's got attention, and it's got the right kind of attention, bipartisan. See the purple nails? See what I'm doing there? So it's very bipartisan, and hopefully we can come to some common sense solutions on how to make sure that what we're bringing into this country is of high quality. There was just a recall of a whole bunch of over-the-counter stuff because of cross-contamination from a known provider that has been kind of, having some problems with the FDA in the past and might have been in that book, Bottle of Lies by Catherine Ebon. So you might want to watch your labels and where you're getting your stuff. So anyway, back to obstruction. In terms of the upcoming clinical trials for people with obstruction, you want to go over some of what might be available to people to participate in coming up. A lot of these trials are closed now, but what's up?
You mean in terms of, I think we're going to, what's happening now is that I think the one that's starting to really gain some traction is Edgewise for Cirrus, which I believe is non-obstructive and obstructive. That's the current one that's ongoing for from Edgewise, and it is for me at least, it's somewhat of an unknown mechanism, but I think that's our option right now for that. There is other non-obstructive. Predominantly, the study is called. That's another option. I think you can enroll both obstructive and non-obstructive, although I am thinking of that as a non-obstructive predominantly. That's SGL1 and SGLT2 blockers. Both of those are engaged in that study. And then Imbria. So Imbria, I forget the name of the study, is
Fortitude.
Fortitude, thank you. Fortitude is the newest one that has just started to really pick up some speed. It's really starting to enroll. So again, I feel like every time you go to your doctor, you should be saying, are there research trials for me to be included in? So are you symptomatic? Do you have elevated blood tests? I've ordered more pro-BNP in the last 3 years than I probably did in the decade prior to that, looking to see if they're elevated, to see if you qualify, and at least begin the conversation. And if it's elevated, then we should have a conversation. Do you want to get involved in one of these trials, or should we try one of the other options that are currently available? So those are the big three that I'm aware of right now. I don't know that there's another primary obstructive trial going on.
Not in the United States that I know of.
So overseas, this is obviously starting to roll out. Mavacamten and Afi will start to come out overseas. I think you're going to see a lot of it in, China. It's really starting to pick up speed. Lots and lots of people there to treat.
Lots of people in China to treat. Lots of interest from China to get better at this, and they're being quite innovative with their surgical approaches. And I'm kind of looking forward to see if we can address. They have a new tool to do a myectomy on a beating heart in a very different way, but that tool is not approved in the United States yet. I hear it's scheduled to go in front of the FDA in 2026, and there might be another surgical option coming because, of course, we need more ways to abuse the septum. Or torture it, whatever we want to call it. So, there's more tools in the toolbox being percolated as we speak. So, any thoughts on what's going on over there?
Yeah, I think when you hear about that new technique that's evolving, they've done a lot of them. They claim to have a lot of experience. It's like a corkscrew, essentially, right? You go through the apex of the heart and you kind of corkscrew it in and corkscrew it out. The heart's beating away. It sounds unique. A couple of our friends have been over there to watch it live, and they tell me it is pretty cool. And if that can innovate this and make it a little bit easier to assimilate into the broader community, I'm all for it. One of the challenges right now, and I'm going to really step on some thin ice here, is the surgical community who has expertise in myectomy is a seasoned group. They are a seasoned group of surgeons. And as they start to season into retirement, it's going to be tough to see who's going to pick up the baton and carry it on. I think training in this is really hard, right? If from the patients, you're looking down kind of a quarter-shaped opening, right? Just a little bit, looking straight down into the heart. And then you've got to find the area that's the problem, shave that out, but don't go too far. Don't hurt the aortic valve and don't hurt the mitral valve. And then should we be plicating the mitral valve? And I will tell you, I've become more and more of a fan of plicating the valve over the last 5 or 6 years or so. You can do a myectomy that's really, really good, but if the anterior leaflet is really long, so 29, 30 or longer, it is often still a troublemaker after you're done. So I think giving your added benefit of plicating the valve. So for patients out there, we fold it on top of it and then we sew it. So the valve is too long, they fold it and then just sew over. Sometimes a lot of sewing to keep that valve from, and it just shortens the valve and takes it away from the outflow tract. I have found that to be, when in doubt, and you can do it, plication really helps. And I watched Rostegard do this for a long, long time. And
Swistel does it too. Yeah.
Swistel does it well. Sorry, Dan, if you're listening, I send you a lot of people. And Nick's Madeira also does it very well. Our surgeon is learning this too, because we've recognized that removing the muscle is often not enough. You really have to do something extra.
So some people know this story and some people do not. But when you look at my heart, when you hold it in your hand now that she's, free, you can see where my scar tissue formed from my endocarditis. And interestingly, I gave myself a biologic plication, I guess you could call it, because the scar tissue made my mitral valve stiff. But that took my gradient from 90 to nothing by pulling that mitral valve out of the way. It's not a therapy that I would recommend to anybody at any time. However, the mechanism is clearly there that accomplished the task. And so I've always kind of thought that it made sense to me because my mitral valve becoming more stiff and pulled out of the way did create a positive environment that reduced my gradient. So I think it's by personal experience and then seeing so many people have either mitral valves who are cut or plicated. Some of them are just cut off, depending upon the technique. But either way, it is not just doing the surgery down a garden hose. You're then taking this very delicate apparatus of the mitral valve leaflet and you're stitching it. And it is an art form and it is very, very, very hard to teach. We need to ensure, part of the reason I am at the Rally for Medical Research is because not only do we need to fund research, we need to help young scientists become better at what they do. We need to train the next generation. And we're losing it now, people. We are losing people. We are losing people to retirement. And there's not enough coming in that are seasoned enough or skilled enough to take on some of those skill sets. And myectomy is one that we are in danger of creating extinction. And it can't go away. It's too important.
Yeah, absolutely. You just touched on something that made me think of this. We didn't talk about it earlier because it's never really taken off, although it is in my back pocket, is the MitraClip. So the MitraClip is obviously, if the mitral valve opens, you can clip it so that part of it still opens, but part of it closes. And as you say, it kind of pulls it out of the outflow tract obstruction. Paul Saraja wrote on this, maybe 10 patients or so. It's never really taken off. Part of it is because the MitraClip is really expensive and it's not approved for this. So you sort of have to, it's a bit of it's a compassionate use in some ways.
Yeah. I've been excited about MitraClip as an option specifically for older individuals for whom the surgery might just be too much. And that's who we've seen it done in most effectively. And it does work in them, but it is rare. From Pakistan, septal non-obstructive, is it possible to reduce the thickness without a myectomy? Will that be expensive? So to our friend from Pakistan, can you explain why we don't do surgeries in non-obstructives?
Yeah, so the reason to do the surgery is to open up the outflow tract and eliminate SAM and obstruction from preventing blood flow from leaving the heart. So you're opening up that. In non-obstructives, by definition, there isn't any obstruction. There's no SAM, there's no septal contact. It's 30 millimeters or less. There's a little bit of a back step here. I'm going to say that sometimes if you have a mid-cavitary obstruction, which is not the same as an LVOT obstruction. So a mid-cavitary obstruction is when the muscle is so thick in the middle that it actually kisses in the middle. And that's often one of the mechanisms that forms that aneurysm below it. So if you have an aneurysm, you may have a mid-cavitary obstruction. There are some that think this is a mechanism for relief of symptoms. So yes, there are folks who might have a ongoing chest pain, intractable breathlessness, intractable symptoms that you might consider going in and doing a apical surgery to remove that extra muscle. I would tell you that that's still very much reserved for a smaller group. It is in my experience, the ones who have done it, they still end up going to a transplant long term.
And then you've got a double opening of the chest, which creates problems post-transplant. Yeah.
Right. So you delay the transplant, which you can, again, have that conversation with folks. But I say exactly what you said, which means we're going to open up your chest twice. And for those who don't know, after you open somebody up once, there's scar tissue. Everything gets sucked down and more firm. It's harder to separate the tissues. So it can be a little more challenging post, and it's a second cut through the sternum. So in general, I would say septal reduction therapy for non-obstructive is the exception, not the rule. It is the rarity. I would ask a friend. I would certainly get other opinions before we went on to non-obstructive surgery, and that's the reason why.
And in Pakistan, I do not believe that you have an adequate surgeon who can do a good regular myectomy for obstruction, let alone an apical myectomy for the opening of the ventricle. So I wish you all the best, and hopefully we will get some medical therapies to you for the non-obstructed soon that will make you feel a little bit better. We're working on it, my friend. We're working on it. We're working worldwide. It doesn't matter where your big heart is. We care about it. So we're trying our best. Matt, I want to be respectful of your time. I know you're in Brazil and you have someplace else to go. So I wanted to get to some final comments before we wrap. So I'm going to pivot to, where we were just hanging out a couple weeks ago in Nashville, and talk a little bit about some of the work we're doing with ASE and some of the innovative training that happened at ASE this year.
So for the last few years, but certainly for this last one in Nashville, because it was the 50th, we are training sonographers about how to do a HCM specific portion of the echo. So for those of you who have had echoes, who perform echo or read echo for the docs, the echo isn't much different than a regular echo, but it is now focused. We want to add on a couple of focused things to look for: the outflow tract, the mechanism, the mitral regurgitation, leaflet length, SAM, septal contact, and then quantifying the obstruction. That leads me to how well are we assessing for obstruction? So if we believe this is a disease of obstruction, which we do, the majority of patients with HCM will have obstruction. More than a third of them, in many scenarios, require an extra step to bring out that obstruction. So traditionally, we do this by Valsalva, where we bear down and have people do a sit-up. And it's the challenge with it is it's not reproducible. Everyone does it a little bit different. Patients understand the directions a little bit different. We explain the directions a little bit different. So you get a little bit of a variation across the board. Others have said, well, I have them blow into a straw. I have them blow into a syringe and kind of push off the top. But none of those are, again, the same every time, right? The patient may blow very quickly into that, or it may be a short burst of this. So the way we do a proper Valsalva should be a breath where you bear down, hold your breath, and you're going to increase your abdominal muscles, and you're going to blow out for at least 8 to 10 seconds to get that obstruction. So at the ASE, we introduced goal-directed Valsalva, where we were training sonographers. We didn't introduce it, but we trained a whole bunch of folks on goal-directed Valsalva, where I think over 300 sonographers went through this training to bring it back to their institutions, where you blow into a tube that is attached to a blood pressure cuff, and the patient doesn't have to take a big breath. They just blow, and they blow gently into this until the blood pressure cuff rises to 40 millimeters of mercury, and then we have them hold it for 8 to 10 seconds or so. And when you hold it for that, it's very reproducible. It is literally goal directed, and the goal is 40 millimeters of mercury, and everyone does it the same way without those big breaths. So it doesn't eliminate the pictures. It's reproducible. And by the way, it shows the most, it's the highest gradient you will get compared to resting traditional Valsalva. Goal-directed Valsalva seems to have the highest gradient across the board. And for those who are on myosin inhibitors, it will prevent you from needing a dose reduction, which we often do if the gradient isn't high enough at that first 4 weeks. So we show data on this, somewhere between 25 and 35% of folks who would have been deemed non-obstructive, we deemed obstructive, and didn't have to reduce the dose, or we were able to increase the dose and make people feel better. So that innovative therapy, elbow-to-elbow training, where you're getting experts in the field. So sonographers, training sonographers about the tips and the tricks and rolling people and little subtleties, that really mattered. Kudos to the ASC and Ted Abraham and Dermot Phelan for engaging us in this so that we could better train the sonographers. Cody Fry, Margaret Kronides, and Amy Dillenbeck are the 3 sonographers that are leading this nationwide. 3 superstars. They can help train your sonographers if you didn't get to ASC.
So the other piece that was super cool is the patients who were actually present. We had 5 volunteer HCM patients with various anatomies come to be training the sonographers. So thank you to our 5 volunteers. We gave them all kinds of different anatomies this year, Matt. We gave them obstructed, we gave them non-obstructed, we gave them myosin inhibitors, we gave them an apical, and we gave them an apical with an aneurysm. So they really got an understanding of the variety of HCM anatomy, and we're looking forward to doing it again next year in Colorado with ASC, as HCMA and ASC forged together in a new relationship that we're currently defining. So right now it's just a relationship. So it's
I will tell you, for the patients, thank you for doing it, because there's nothing better than learning on a patient, on a real person, rather than a simulator. It adds great value, and you provide feedback that we don't normally get. Number one. Number two, there's nothing better than having you in the audience coming up to us afterwards. I had one individual say to me, "I didn't realize how much all of you are doing to try and escalate the game for hypertrophic cardiomyopathy." And we're trying, right? We're doing Lisa has been doing this for a long time, but we're obviously continuing to drive this. So coming to these meetings may be of real value to you to see kind of what's cutting edge, what's coming, and wondering, am I actually getting a good echo in my home institution? Maybe I need to make sure that they upgrade their game. I'm not saying switch providers. I'm saying that maybe we need to provide some feedback that a 10-minute echo might not be sufficient for a comprehensive cardiac exam for an HCM patient. So you can be the champion in your own environment. So thank you, all of you, for coming to those. It actually is energizing for those of us who meet you.
The sonographers, the physicians who were coming in to do the reads over the sonographers, they all came over and complimented every single one of the patients who participated. They were engaging, they gave feedback, and they made the learning experience more whole and more complete. So thank you all to that. And if you live in the Colorado area and you're interested in doing something like this next June, you can reach out to the HCMA office and say, "I'd like to volunteer." I think we're going to get a little bit more. I didn't publicize this the first time we did it, and now I'm making a bigger deal out of it. So I think we'll get some more recruits for June next year. And we're looking forward to that partnership with both ASC and IAC, which accredits laboratories, and they're creating an accreditation for HCM imaging, which we're looking for ways to work with them on as well. So we're really excited that the patient's voice is being heard at every level of the game, and it's permeating through the entire ecosystem that is HCM. So I do have a couple of other announcements. Matt, is there anything else you wanted to wrap up with on septal reduction September?
Well, this was awesome. Somebody just popped one in quickly. HCM with obstruction, do you have a myectomy if no symptoms? Ooh, really
Good
important.
one.
So no, in general, first of all, you need something. How high is your gradient? If it's really high, I'm going to submit to you that you need an opportunity to prove it. So I want you on a treadmill to make sure that you're actually asymptomatic. So if you have a significant obstruction at rest or with provocation, I want to know how far you go on the treadmill to make sure you're truly asymptomatic. But in the asymptomatic group, we're still not quite there where the medical therapy or the surgery carries a little risk to outweigh the benefit. I think we're going to get there. I think that over time, there's going to be a change in our paradigm with how we approach those with a elevated obstruction and no symptoms. There may be benefit long-term, but we need data on that. So at least for now, big time obstruction, prove it to me with a treadmill study. Make sure that you're actually exercising as much as you think you are, that you're as lack of symptoms as you think you have, and then we hold. We just wait. And eventually, you will likely develop symptoms, and then we'll discuss what the risks and benefits look like. Great question.
I'm going to give a qualifier on this one. Pediatric cases. If we're talking about a kiddo with a really high gradient, can you address that, please?
Yeah, so even more complicated. So because we worry that the earlier you develop HCM and the more obstruction you have as a younger individual, the higher the risk that you're going to have heart failure and complications long-term from that. So that does change the paradigm when you're under 16 to 18 years old, for sure. And they're not as reliable with symptoms, right? How are you feeling? Good. Can you exercise? Sure. You need a little more than that. So you got to dig in. So you got to really pull out whether or not they have symptoms or not. Again, the treadmill's on there. But if you've got elevated obstruction and you're young, I'm worried about you. And since we talked about research earlier, by the way, there's research coming out on pediatrics for there's a CEDAR trial that's ongoing, aficamten, enrolling patients. We're one of those sites. We enrolled, I will say, the first myosin inhibitor in the world in our institution. He's doing terrific. I won't say his name, but he is he's doing terrific.
Yeah,
and
an amazing young man. So yeah.
Yes. And more to come, and brave, as you say. And the mavacamten trial is completed for peds. I don't remember the name of it. Scout is already completed. So we're going to gain some data in this group. I think, as you are pointing out, in that younger group, may be an opportunity to treat people before the symptoms occur, to prevent some of those long-term issues and reduce the wall thickness, improve the diastology. Now we're talking about prevention, and that's an exciting place to be for HCM. We've not really been there before.
Thank you so much for that. I want to be respectful of time. If you need to drop out, that's great. I do have a couple of announcements, some you might be interested in. So for some of you out there, you may follow things called executive orders that come out of this place around the corner called the White House. And there was an executive order about a week ago about direct-to-consumer advertising for pharmaceutical agents. The directive was a little non-specific. And I've been reached out from a couple of different pharma companies asking, what do the patients think? So rather than taking anecdotal comments that you've made to me over the years, in a few minutes, I'm going to drop a link. I was working on it before we got on podcast this morning, but we put together a very quick survey. We want to know what you all think about direct-to-consumer advertising. Whether you're a physician, you got to sit and watch it too, right? And it's for things that you might have, not what you're prescribing for. What do you think about it? If you're in industry, what do you think about it? If you're a patient, if you're a family member, what do you think about it? And if you could, send this off to your friends as well. We want to know what everybody thinks. I don't care where they come from. I think some of them are really helpful to understand different diseases that you didn't understand before. I like the disease awareness campaigns more than the buy a drug campaign myself, but that's my personal opinion. And I think some of them are a bit campy and like, we're not all dancing in the streets, for Christ's sake. We're just living our lives. So some of them have an unrealistic view of reality, I think, and some of them set bars too high. If you don't like start dancing in the street, did the drug not work for you? So there's like some things that you can comment on. So, and I told one of the individuals from the pharmaceutical company that, when I was in heart failure waiting for my transplant, and Entresto was being marketed very heavily, and every morning I woke up to the sun will come out tomorrow and living with heart failure. I hated that commercial beyond words. I hated it. I would hear the song and I would cringe and I would turn the TV off because it made me feel like I was failing because the drug wasn't helping me. So I've had my own relationship with direct-to-consumer ads, but I want to know what y'all think. I think there's some value, but are they transparent enough? Should they have price included in them? Who do you trust to give you information about new drugs? Is it your doctor, your pharmacist, your patient advocacy organization, a friend, a family member, pharmacy, the government? Who do you trust? Where do you want the information and how do you want to get it? So we're going to send out a survey on that. And I hope you all take a moment to answer it because it is important. It's a very short window of time we have to collect this information and disseminate it. Ross, if you could drop the QR code for KCCQ-HCM, please. That'll probably take them a minute to find, so I'll ramble for a second and explain it. In October of 2023, the HCMA convened a working group to address clinical trial endpoints in HCM and to see what we could do with information out there to move the ball a little bit so that when a drug went through a trial and got to a payer, we had real data to say it works and here's how it works and here are the numbers proving our point. And we've been using something called the KCCQ to measure heart failure symptoms for a long time. And it's fine, except it's not specific to HCM. So we've been working with the team at KCCQ, so John Spertus and Charles Sherrod. Sorry, Charles, forgot your last name there for a second. But we've been working with their team to create HCM version of KCCQ, so KCCQ HCM. We're looking to modify a couple of questions that more closely reflect the HCM experience with and without obstruction. Everybody tries to separate it into non-obstructed and obstructed kind of tools, but that doesn't work. So we want a tool that can measure your improvement when gradient disappears, but also measure the underlying burden of that thick HCM heart. So if we could drop that link again, it might drop after the podcast ends. We'll get that out to everybody, and we need to hear from everybody on that one. We've got about 300 respondents right now. I'd like to see it at 600, but the format looks a little bit different than our typical format. So some people may not trust it as an HCMA endeavor. It is, but it's done through REDCap, which is a research database. So it looks a little different than our slick, SurveyMonkey pretty ones. So please take that into consideration and take that survey. In fact, we'll do a blast email out to the entire HCM community today on that one to get more feedback. So you'll be hearing about that one. I see Russ kind of giving that look behind the scenes, and he's going through screens. I can see it right now. Okay. And then I will go finish the survey on the direct-to-consumer advertising. Your voice matters now more than ever when it comes to public policy about health insurance access. And I do want to give you another update from the Hill real quickly here. When we got here 2 days ago for the Rally for Medical Research, we were given some new data. And this is exciting data to me. 89% of Americans agree that the federal government should fund medical research at the National Institute of Health. And there is a strong belief that this will actually happen. The proposed budget asked for a 40% cut to the NIH. However, the Senate bill version adds $400 million to NIH research, and the House bill adds $99 million. So there's probably not going to be a cut as long as we can get a budget and appropriations done. But it looks like that funding will continue, and that is the will of the American people. Your voice matters. Learn how to speak up, where to speak up, when to speak up. It is more important now than ever. The other issue that is coming up that is really important, and we need you to speak to your elected officials and share your view on what should happen, is access to Medicaid and ACA subsidies. If ACA subsidies go away on October 1st, that is less than 15 days away, right? So if those fundings go away, premiums for families will increase upwards of 75%. I even saw one that increased by 200%. So that's not the world we live in. We can't afford this. People are going to get sick. They're going to get hurt. They're going to need medical attention. We need to make sure that people are safe and covered and not going broke because they got sick or they have a chronic disease. So I think we all agree that we need physicians and we need medicines and we need new treatments, and that somebody's got to pay for them. And we're not asking for anything for free. We pay our premiums, we pay our portions, but it's becoming economically impossible for some families to get there. And if we're going to do the work that we need to do in diagnosing more people with HCM, it does us no good if they can't get access to the life-saving treatments that we have today. So let's make sure we all have the opportunity to live our best life and our healthiest life with the support of our healthcare systems and partners. So your voice matters. That's why I'm in DC. And I thank you all for supporting our work to support you. So on that note, Matt, I will say goodbye from DC, and I wish you well in Brazil. The food is amazing. The people are lovely. I hope you have a great trip.
Thanks for the invitation. Always a pleasure to be here. I'll see you soon, I'm sure.
All right. Well, take care. Bye-bye. Thanks, everybody, for joining.
Bye-bye.
I'm going to drop that survey link in just a minute. Thank you all for joining. Have a great day and a healthy one, too.
The Hypertrophic Cardiomyopathy Association would like to thank our sponsors, Cytokinetics, Bristol Myers Squibb, and Edgewise Therapeutics.